Nielsen. I'm the CEO at the Patient-Centered Primary Care Collaborative, and I'd like to thank everyone for joining us for our presentation. I am most delighted to share with you some of the hard work that the PCPCC has been embarking on the last several months, and that is the recent report entitled The Patient-Centered Medical Home's Impact on Cost and Quality, a review of the evidence 2013 to 2014. Of course, releasing our report on the heels of the fantastic news that we received this week from the Secretary of HHS regarding their goals to expand payment reform and value-based payments across Medicare, and encouraging more of the private sector to do this work, along with the terrific news that came out of the Comprehensive Primary Care Initiative, as well as the MAPSIP initiative, the multi-payer initiative that states are embarking in. It's all kinds of terrific news here at the PCPCC, and our report is just one more piece of that good news. I do just have a couple of announcements and housekeeping items before I begin. We are going to be releasing this report on Friday at a Capitol Hill briefing. We unfortunately don't have more room at that event. The registration list is full, but we'll be recording that particular briefing, and so folks will be able to hear the same review of our report, but also see the very interesting conversation that we anticipate our panelists and the audience will be having. And then also, we hope that folks will be able to join us on Tuesday, February 3rd. We'll be having a webinar that features Dr. Mark McClellan from the Brookings Institution, who's going to be discussing the important role that primary care leadership plays in healthcare transformation, specifically that including physician-led accountable care organizations and other payment reform initiatives. And last but not least, the housekeeping piece of this. Again, we ask folks to please use the webinar software to ask questions or provide comments during this webinar. And to do this, you just submit your questions in writing using the drop-down question box, or you click on the raise hand button that's found on your screen. And during the last 20 minutes, we'll be opening up the webinar for Q&A from the audience, and Amy Gibson will be managing that. As always, we're going to be recording this presentation, and we will be providing the slides and the recording to our website within the next 24 hours. So without further ado, and if you look to your screen, you see the title page here, The Patient-Centered Medical Home's Impact on Cost and Quality. Next slide, please. And this work, we would very much like to thank our lunch sponsor for the Capitol Hill briefing, which is the Blue Cross Blue Shield Association, as well as the report sponsor, and that's the Milbank Memorial Fund, who sponsored this year, as well as last year and in previous years, the work on our evidence report. We'd also like to thank Senator Charles Grassley from Iowa, who is hosting our Capitol Hill briefing. And you can see there the logos from our friends at the Milbank Memorial Fund and Blue Cross Blue Shield Association. Next slide. The overview of our report, I'm going to give you some background on how the report was put together. It is similar to years past. And then I'm going to be specifically talking about key points number 1 that really look to that evidence and what we learned from the evidence. Key point number 2, which is we've got to be investing in primary care in new ways if we're sincere about achieving the triple aim and having success that is sustainable. And then finally, discussing some future directions for the patient-centered medical home and primary care, and I'll be talking in more detail about better integration, financial support for the model, the importance of team-based training, certainly patient and consumer engagement, as well as the role of technology. Next slide. We provide you with some information about the Patient-Centered Primary Care Collaborative, as well as the Millbank Memorial Fund and Blue Cross Blue Shield Association, both longtime supporters of the work that was started in 2006. Our president, Paul Grundy, at IBM, together with the Primary Care Associations, started this work and expanded our list of collaborators to be almost 1,300 strong today. We are happy to have a new board member, Dave Hebert, just joined the board, who represents the advanced practice nurses. Next slide. And we would like to thank our guest authors who helped write sections, the final section of our report. You see them listed there. I'll be calling them out again at the end of my presentation, but thrilled to have great collaborators across a number of different organizations. And of course, we had a number of fantastic reviewers who you can see listed in the report itself. So I'm going to tell you about the report, and I'm going to ask for the next slide. The news continues to be positive. I've mentioned the good news that came out of the Secretary of HHS's office in terms of supporting the PCMH model of care as well as accountable care organizations. What we've done at the PCPCC in this report is we're looking at the new evidence from the last year, and indeed it does demonstrate improvements in cost and in utilization associated specifically with the patient-centered medical home. I might point out that this is what we found this year was the largest number of PCMH evaluations in a single year. So there were 28 publications that we detail for you in our report. Out of those 28 publications you see listed here, 17 found improvements in cost, 24 found improvements in utilization, and I'll come back to that momentarily. 11 of them found improvements in quality, 10 found improvements in access, and 8 found improvements in satisfaction. That was either in patient satisfaction or in provider satisfaction, and I'll talk about that more in a moment. Next slide. We used similar methodology this year as we did last year, and that is we specifically looked at medical homes and patient-centered medical home studies published between the months of September 2013 and October 2014, and we looked at 3 different kinds of reports. First and foremost, we looked at the peer-reviewed literature. Then we also looked at state government program evaluations. You'll see, in fact, there were several state reports that also landed in the peer-reviewed literature. And so there you'll see state reports under peer review, under state government reports, but also some of the industry reports link back to state activities. We did do a search for articles that fit a specific research criteria, and that is we looked at exploring the relationship between medical home as a predictor variable, and we used several terms for this: medical home, or PCMH, or advanced primary care, or health home. And then we looked at whether or not there was an associated dependent variable or outcome variable on cost or utilization. So independent variable, medical home, dependent variable, cost or utilization. This resulted in 14 peer-reviewed studies, 7 state studies, and 7 industry reports. Now, I did just want to underscore, and you won't see this in the presentation today, but you will see it in the full report itself. This report highlights in great detail what the findings are from each of these reports, selected into these following categories. The first category was cost and utilization. So here we were looking at emergency department use, inpatient admissions, readmissions, expenditures, or reported outcomes directly related to cost. So that was column number 1. Column number 2, we report on population health and preventive services. Next column, column number 3, access to primary care. and that included overall access to primary care clinicians and services, as well as non-face-to-face visits. And then finally, on patient and clinician satisfaction, which included survey data reported by patients, staff, and clinicians. Do want to point out, when you look at the tables that expand across many pages, a blank space within a table is an indication that that particular report contained no information on that outcome, either positive or negative. So it shouldn't be interpreted as a failure to achieve improvement. And then also want to point out, our review isn't a formal meta-analysis, as though an academician would do. Instead, the evidence for this report does not include null findings or outcomes that failed to reach statistical significance. We try to make these tables as sort of user-friendly as possible. And so if there were no findings or negative findings, or they didn't find statistical significance, they aren't included in our table. We did try to stick with the language that the authors used and use corresponding p-values and provide as much quantitative data as is possible. So with that, next slide, what did we learn? Lots of folks are very focused on the peer-reviewed literature, recognizing that a committee of peers goes through a research or study authors' proposed findings and asks questions, asks for improvements before information is published. And so we were very pleased to see that there were 14 peer-reviewed studies on PCMH outcomes. You'll see I list what those studies examined, and a range of kinds of studies looking at Medicare fee-for-service in patient-centered medical homes that were accredited by NCQA, a number of studies on the Veterans Administration, as well as a number of studies focused on Pennsylvania and their chronic care initiative, a subset of 2 studies that Independence Blue Cross Blue Shield did. So I won't read the list for you, but you can see an impressive set of peer-reviewed outcomes. And importantly, there was very encouraging news, positive trends in cost and utilization. I would point to, starting with the cost, out of 10 studies that reported on cost, 6 found improvements. You see listed here, out of the 13 reports on utilization, 12 reported improvements. And we think that this is really significant. Even when a study didn't find overt cost savings, we did see that those studies did find a decrease in unnecessary utilization of emergency departments and hospital services, which again is important because it suggests that resources are being used more appropriately to deliver primary care, and that perhaps in subsequent years we'll find associated cost savings. We anticipate that good news to be a part of ongoing MAPSIP and CPC studies released again this week by CMMI. And then you'll see, when evaluating the patient-centered medical home to bend the cost curve, what we point to in the report is an acknowledgement that there are a lot of confounding factors when you're looking at cost. Some of those confounding factors include rising medical prices, increases in physician reimbursement in Medicaid, for example, that all affect the total cost of care. So as we discussed with the reporter today, it's important to focus on cost, but cost without also acknowledging quality and patient and provider satisfaction only gets us part of the way there. We also pointed in the review at some of the importance in looking at Medicare and the Veterans Administration. When you look at the Medicare fee-for-service study, they did find savings as well as changes in utilization, even though this was a fee-for-service study. We found that to be very encouraging news. But of course, we think without changing the underlying fee-for-service incentives, providers are still financially motivated to increase the volume of services. So we are thrilled by Secretary Burwell's announcement of pushing towards value-based payments. And then next, want to acknowledge all the work that the VA is doing. And the VA PACT program, the PACT program is their equivalent of PCMH. To date, one of the evaluations looks at all 5 million veterans in 160 hospitals and 783 community-based clinics. And although there isn't a return on investment that is statistically significant, we do see encouraging trends in cost with statistically significant reductions in utilization, which is important for long-term cost savings. We also found improved clinician and patient satisfaction. Again, really important for us to be looking at the big picture here. Next slide, please. Looking then at the state government outcomes. So you'll see we looked at a number of states from all across the country: Colorado, Minnesota, Missouri, Oklahoma, Oregon, Rhode Island, and Vermont. And what you see here, out of 7 government program evaluations, these were not necessarily peer reviewed, but some of them did use outside evaluators. What they tell us is that 7 reported on cost savings and 7 found cost savings. 6 reported on reductions in utilization and all 6 found improvements in utilization. 6 reported on improvements in population health and preventive services. You see 5 of them reported improvements in access, 3 improvements in patient or clinician satisfaction. What we found in these state reports that were incredibly in-depth was a great deal of analysis at a very refined level. We think that the work that states have done really is to be celebrated. They have been longtime leaders in the patient-centered medical home movement. Not only are administrators of Medicaid programs and state employee health programs really embracing the PCMH, but of course many legislators are very interested in these pilots and help fund these evaluations as well as the projects themselves. So these reports tend to be more thorough than what we see in an academic journal, which have to limit the number of words, or in an industry report. Again, if you look at that list of states, it's not a surprise to see how many of them are leaders in the PCMH implementation. Many of these are states that participate in the multi-payer advanced primary care practice demonstration, the MAPSIP project that I keep referring to. And these multi-payer initiatives are quite impressive in terms of showcasing the importance of alignment across payers. Again, encourage folks to take a look at the MAPSIP evaluation that came out this week. That evaluation contains some encouraging news. Next slide, focusing on the industry reports. And again, you see a wide range of folks sharing information this year with the public, from United Healthcare and their PCMH programs to the California Academy of Family Physicians, Care First here in our backyard in Washington, D.C., Blue Cross Blue Shield plans in Maryland, Washington with Care First, in Michigan, long a leader in the patient-centered medical home movement. Our friends at Blue Cross Blue Shield, New Jersey, the Horizon Blue Cross Blue Shield plan, as well as our friends at Aetna, again, longtime leaders focused on patient-centered medical homes, as well as the folks in Pennsylvania at Highmark. What you see here is 4 out of 7 of the industry reports found cost savings. 6 out of 7 reported reductions in utilization. 3 reported improvements in population health and preventive services. 1 was focused, included information on improvements in access, 1 in improvement in patient or clinician satisfaction. Again, these trends are all quite encouraging, and each of these states, each of these industry reports found improvement in at least one metric that they were measuring, but in many cases in many, if not most, of the metrics that they were looking at. So what does this all mean? When you take a step back from this data, next slide please, what does it all mean, and what did we learn as we read through these detailed reports? We continue to see that the healthcare marketplace is making great strides in advancing this model of care, and the number has grown substantially since 2009. But still, primary care providers represent only 4 to 7% of total healthcare spending. And so we need to really think seriously about reinvesting in primary care. And next slide. In terms of the ways in which we think we should accomplish this, and that's not just at the PCPCC, but following the lead of states like Rhode Island, Maine that is interested in moving away from fee-for-service, many other states, but increasing the amount of money, that total percentage of money spent in primary care relative to the total cost of care. That, I think, is something you'll see and hear a lot more about from the PCPCC, and we'll be discussing at our retreat with our centers and following through with a strategic plan from our board. Next slide. And future directions for the patient-centered medical home and primary care. As many of you know, the PCPCC is really a collaborative of members from a very diverse set of stakeholders, to include patients and consumers, certainly their families, caregivers, health plans, employers, folks within the industry, folks across government, and last but not least, health professionals. And we had a number of them, as I mentioned earlier, participate as guest authors on this report. Next slide. And what they told us in terms of the future directions that the PCPCC, as well as all the stakeholders in primary care, where we need to be focused if we want to continue to make great strides in advancing this model. First of all, we need to keep focusing on how we integrate services, both inside as well as outside of primary care practices. So an example of integrating services inside of primary care, how do we integrate behavioral health and oral health, for example, within a primary care practice? Examples of how we need to be better integrated into the medical neighborhood include how to PCMH integrate with accountable care organizations. We strongly believe they ought to be foundational to ACOs. But how do we also integrate with community-based organizations and services? And here, Dr. Kavita Patel wrote her perspective. She works for Brookings. She wrote her perspective on how we can better integrate in the medical neighborhood. And Dr. Matt Longjohn, who is at the WISE USA, he's their National Health Officer, he provides some perspective on how PCMHs should be integrating in the community. Next, as I mentioned earlier, providing financial support for enhanced primary care is incredibly important, and we need to be doing that, focusing on controlling the total cost of care, but while maintaining or improving quality for patients. And Dr. Len Nichols from George Mason University provides us with a guest column on his perspective on how we might do that. Next, how is it that we develop a primary care health professions workforce that embraces all members of the team, and certainly that includes the patient and their family or caregiver? And Dr. Barbara Brandt from the University of Minnesota, who directs the National Center for Interprofessional Practice and Education, provides her perspective. Of course, an effort near and dear to my heart, and that is how do we engage consumers and the public, patients and their family in particular, and here we get a terrific perspective offered from Bev Johnson, who's the President and Chief Executive Officer at the Institute for Patient and Family-Centered Care. She's also a board member at the PCPCC. Bev and her colleagues, Mary Minetti and Marie Abraham, offer their perspective on ways we can better engage patients and families. And finally, making certain that we continue to embrace the potential of technology to support this model of care. We've got quite a long way to go in that regard, and Dr. Jonathan Nyloff, who works as the Chief Medical Officer at McKesson Connected Care and Analytics, offers his perspective. And so, next slide, a few take-home points that we'd want to share with policymakers, the private sector, and certainly the public, and that is we've got new evidence, building evidence, that demonstrates improvements in cost and utilization. And that certainly is something that policymakers and payers are paying a lot of attention to. Are we, in fact, saving money and reducing unnecessary utilization? And the answer is yes. And we've got the data detailed in this report that demonstrates that. Next, if we're sincere about doing a PCMH and ACO and value-based world of healthcare delivery in the United States, we've got to be investing in primary care in new ways. And we're really talking about two means by which to do that. One, looking at the total cost of care, how much we spend, and how much of that total spending is dedicated to primary care, and how we might increase that investment. And then secondly, ensuring that we're moving away from fee-for-service as it drives up volume rather than value, and looking at comprehensive payment for primary care. And then finally, as you might expect from the collaborative, the role of collaboration across these stakeholders continues to be incredibly important and critical to our long-term success. And so we've got some guest authors who are sharing their perspective with all of you and all of us as part of this report. Again, a thank you to our sponsors, next slide, who are supporting both the report as well as sharing this information on Capitol Hill. And thanks to my co-authors on this particular paper, Amy Gibson, who is, of course, the Chief Operating Officer at the PCPCC, Elizabeth Buelt, who is a master's student at George Washington University and a terrifically talented young lady who has worked very, very hard on building this report. As always, Dr. Paul Grundy, who is the founding president at the Patient-Centered Primary Care Collaborative, and as always, Dr. Kevin Grumbach, who is the chair of family medicine at the University of San Francisco. So with that, I am happy to take any questions, and I'm going to turn this back over to Amy Gibson, who will facilitate the Q&A.
Thanks, Marci. Yeah, just another reminder for all of you who are participating. If you want to ask a question or provide some clarification, or even I think we probably have several people on the line who might have participated in some of these studies or programs based on these evaluations. If you want to provide some additional insight or thoughts that you have regarding the evidence on medical home and advanced primary care practices this year, we'd really appreciate hearing from you. So you can type your question into the chat box, into the question box, or we'll even give you an opportunity to ask a question live. If you want to raise your hand, you'll just need to type in your PIN number so we can identify you on the audio. So please do go ahead and,
I'm so
ahead,
sorry. I failed to acknowledge and thank, and she's at the very top of my list, and that is our new manager of communications, Caroline Delaney, did a fabulous job this year, making certain that our report was timely as well as well organized and keeping all the trains running on time. So hats off to Caroline, who made writing this this year's report a pleasant endeavor. So my apologies that I should have thanked Caroline earlier.
Absolutely. So I'm looking and not seeing any questions. I think we might have a couple of hands raised. Stacy, you want to go ahead and see if we can maybe get someone unmuted?
Yeah, Amy, I see that Macron Baird has a question. I'm going to go ahead and unmute you.
Hi, Mac. Oh, we can't hear Mac. All right, it says Mac's line is unmuted, but maybe, Mac, you might need to type in your PIN number. Sometimes that limits us in getting the calls unmuted. So we'll try again in another minute or two. Stacey, you want to try to unmute Dr. Grundy's line? I think Dr. Grundy would like to make a few comments.
Sure, I'm going to go ahead and unmute you, Paul. All right, Paul, you're unmuted.
I'll try to unmute you.
Oh, we got your line unmuted, Paul, but we got a lot of feedback on the line. So I don't know if we've still got some conflict there between the computer and the phone line. We'll try again in just a minute. Marci, you mentioned, we had a lot of exciting announcements coming out from CMS, and certainly we're excited about a lot of these evaluations coming to fruition, and certainly I think this is going to help inform evaluations of medical home in the future. It's really so exciting for all of us, certainly, because thinking about where we started on this path, even just a few years ago, we had just a handful of evaluations, and we certainly talk about evaluation and where we'd like to see some improvements in future direction. Can you speak a little bit more to evaluations overall and maybe some of the potential advantages we have going forward, since we have so many medical home programs up and running now, and we're going to be getting more information coming forward, but maybe also some of the challenges, because we're not always calling them the same thing. Sometimes the models are a little bit differently. I don't know if you want to maybe elaborate a little bit on some of the information that's coming forward in some future directions too.
You bet. So thanks for the question, Amy. And we do spend a little bit of time in our report talking about this. The moniker of patient-centered medical home has actually changed a bit over time, and people are using different names for their different programs. We highlight that, as a matter of fact, there are terminology that ranges from advanced primary care, complex care management, complex primary care teams. Some organizations even have taken their PCMH programs and converted them to ACOs, the title ACOs, as their programs have evolved. What we do at the PCPCC in this report is we look specifically at the PCMH programs, but we are tracking those PCMH/ACOs that have at their core enhanced primary care as part of our PCPCC innovation map. So you can look to this report and see details of 28 recent evaluations, but if you look online, we actually describe 500 different initiatives, and many of those initiatives are now evaluating the results of what they've learned from their initiative, and we're sharing that information on our webpage. We have the capacity as part of our website to actually search on a whole variety of different outcomes to include cost and utilization. And folks can then look at multiple years of peer-reviewed studies or industry reports. So the news is continuing to be quite positive. The longer that a PCMH is at it, the more savings we see and reductions in unnecessary care. But there is still a fair amount of variation across medical homes and how they're implemented. So if you've seen one PCMH, as we like to say, you've still seen one PCMH. Most practices that transform do so in a way that works for their patients and families and in specific regions of the country. And so we shouldn't expect for all of them to look alike. That isn't really the goal. The goal is really to have a cultural transformation, to put patients at the center of care, to coordinate that care for that patient across the medical neighborhood, and to do so really using a team of providers, whether they're all working for the practice or whether that team is created virtually in a community. And so the evaluations might vary some, but we're collecting all of that evaluation information and putting it in our innovations map.
Yeah, I think everyone, if you haven't already had a chance to look at the map, there's a great more depth of information on a lot of these programs from whence these studies and reports came from. You can get a lot more detail on different payment models, who the various partners are. So I would really encourage you to go and look at that information. And again, because this publication comes out once a year, we know that we're always pulling up more information as reports become available and putting them up in real time on our website. So all throughout the year you can get very timely information about these programs and new ones that are coming out every day, really. We encourage you to use that information on the map and share that with your colleagues and your partners. You know, one other question that comes up, Marci, when we have conversations about the differences in especially cost as it relates to medical home, certainly we advocate for everyone to have access to a medical home because so much of what's important in a medical home is that trusted relationship, that ongoing continuity of care between patients and a primary care team. But we also often see in some of these evaluations that the cost impact is more significant on those with chronic conditions. Do you want to speak a little bit about some of the variation we see in the cost reports as it relates to more segmented populations, as it relates to outcomes and costs in medical homes?
You bet. It's a terrific question. So as you point out, you do, in fact, if you look at where PCMHs are being implemented and where you see cost savings, it is often first in those subpopulations of folks who are chronically ill because, quite frankly, that's where the spending is. In any given population of Americans, the folks who are spending the most money on health care are going to be the first subpopulation where you'll be able to achieve savings as you start to transform a practice. What happens, though, if you stop there, if you think, I'm just going to focus my efforts inside of my practice on the super utilizers, as we like to sometimes call them, is two things. One, we miss out on an opportunity to really change the culture of a practice. I don't think I've ever met a provider who only wants to focus on those patients and families who are chronically ill and doesn't want to have patient-centeredness as a focus for all of their patients. So that cultural change, that practice transformation that isn't always necessarily well captured in a recognition or an accreditation program, that culture change is incredibly important toward health system transformation. Secondly, if all we focus on are people who are chronically ill and we don't provide patient-centered care, better care coordination, better customer service to our entire population, of course we're missing out on all the public health and population health benefits of keeping a population well that is already healthy. And so the notion, again, that we'd stop PCMH kind of care the reality is we will always need in primary care settings to be partnering with specialists, with hospitals, with other kinds of care providers for people who have a lot of complex illness. But we want to be able to provide this philosophy of care for all patients.
Yeah, I think that sometimes we get caught up in that question of who is the medical home most valuable to, or should there be certain segments of the population in medical home. But I think to all your points, Marci, we really are seeing that it's important that we build this as a way of transforming the whole primary care setting and making all of those services accessible and flexible to the population that's being served in that broadest sense. So I think that a lot of the programs are starting to play out that way. I don't know, Marci, I'm trying to remember if there was any, we got a kind of a question along this line, that were there any studies that really looked at the difference between medical homes in small or medium-sized practices as opposed to larger, more integrated practices? I'm not sure that there was any particular breakdown on that front as it's related to cost and utilization on the outcome side.
There wasn't as part of our evaluation, but there were a few reports that came out this year, again, getting back to the methods that we used to generate this report. We were first and foremost focused on cost and utilization. I know the Commonwealth Fund took a look specifically at smaller versus larger integrated practices and found, in fact, that many smaller practices do well and sometimes better on outcomes. But there was a recent health affairs study just this month that looked at large and small as well as medium-sized practices. And what it found is that larger integrated practices adopted more of the processes involved in PCMH. They didn't look so much at outcomes, just the processes. About 50% on average of processes associated with PCMH were adopted by larger practices, and only 30% were adopted by smaller practices. So there is some difference. I think a fair amount of concern, certainly from folks in rural areas. How is it that you have all of the resources and the payer mix that helps support the needed infrastructure when you try to shift to this model of care? Easier to do in an integrated, larger practice where you've got potentially more resources and a more diverse payer mix. So this will continue to be something I know that the PCPCC is focused on. Certainly we know CMS in their recent call for transforming practices is looking at those practices that have had some challenges in being able to implement this model of care.
Yeah, I just wanted to give everyone one quick last call out for questions before we wrap things up. This is not specifically related, Marci, to the report, but could you speak a little bit to what you anticipate in regards to the environment as it relates to maybe SGR or other parts of the ACA as we're looking to some of the programs that might be wrapping up, whether or not we're going to see some changes and expansion on some, but more specifically around that payment towards primary care. Do you see any short-term encouragements on the horizon as it relates to how we're paying for primary care on any of those fronts?
I do, and I think the news again this week from the Secretary is terrific, and I'm guessing that we aren't able to get Paul or Mac, we can't hear their voices on this call, but if we did hear Paul's voice, and I'm going to try to channel him now, The terrific news with this announcement is the Secretary has announced we're going to move from 20% this year for value-based payments to 30% next year. And if you try to read between the lines, what we see is an expansion of current programs that are investing in primary care just inside of Medicare alone. That's terrific news, and we hope that that means an expansion of the Comprehensive Primary Care Initiative into other states. We're keeping our fingers crossed. Same thing can be said for MAPCIP. We saw that the multi-payer expansion demonstration project was expanded for most states, which is terrific news. But I think that there is a real hunger on Capitol Hill to finally, for once and for all, address the sustainable growth rate, to fix it and get rid of it. And as Amy, our audience is probably well aware, the bipartisan bicameral agreement that was agreed to last Congress really invests in exactly what we're talking about, which is advanced payment models that support patient-centered medical homes and support accountable care. And so I suspect that the announcement from the Secretary will lead to more good news from our friends on Capitol Hill who want to build on the momentum. This notion of shifting away from volume-based care to value-based care is very much a bipartisan approach to improving our healthcare system. And of course, as I mentioned earlier, lots of states have been taking the lead on implementation of PCMH. We hope that there's an interest in Congress to keep supporting states to do that work, and we know that Medicaid in its managed care contracts is shifting to do that very thing, as well as the Medicare Advantage program, which is a terrific example of ways that you can both save money as well as improve outcomes.
Definitely. And just another shout out, there was a mention in one of our questions/comments back to the issue of small and rural practices. There are several that are participating in the Comprehensive Primary Care Initiative being run through the Innovation Center at CMS, and that evaluation that you mentioned that just came out on Friday are showing some great outcomes. So I think that that's another great example of different types of practices that are participating in these new models of care and different payment innovations that are showing excellent outcomes. So I encourage, again, everyone to go and take a look at that evaluation that did come out, that report, because we're really excited about that. So I'm going to toss up one final question that came in, and you kind of talked about it already, Marci, about the importance of the medical home being connected more largely to specialists in the medical neighborhood and all of the other providers of care if we really want to transform the overall healthcare system. Were there, in particular to our report, do you recall if there were any studies that did look at the involvement of specialists, whether as an extension of the care team or in the ways they were collaborating or coordinating care with specialists as part of the outcomes that were mentioned, or were they not part of any of the studies that we looked at for this particular report?
Thank you, Amy. There were actually several that mentioned the importance of specialists and mention the link between a strong primary care practice that's linked to a specialist, specialty group, etc., that are coordinating care in a patient-centered way. As you look to the various metrics that we tracked, readmissions was an important one, and I think it is a perfect example of a place where primary care articulates with the broader medical medical neighborhood, and it can't just be that one or the other is focused on reduction of unnecessary readmission, but it's really got to be both. So yes, the role of specialists were highlighted in several of the reports. We don't have a column that calls that out specifically, but you'll see in a couple places when we track utilization. In some places, there were decreases in specialty care. In other cases, there were increases in specialty care. It was really sort of specific to the study.
Thanks, Marci. And certainly that's also been a challenge for us when we're tracking many of these programs on our map. You know, you already spoke to the issue that we're trying to deal with because not everyone calls it patient-centered medical home now. They call it many different things. And many, you know, organizations that started with a real sound core foundation of patient-centered medical home have migrated everything into their ACO model. And so they almost are using the term ACO to describe what's already been happening around their changes in primary care. So it's kind of nuanced, and it's a little challenging for us to really pull apart what are those specific elements that are making those outcomes what they are, you know, whether we can attribute it and understand and appreciate what resources are really going into the primary care that are driving that, whether it's the collaboration with the specialists and the other providers of care within these larger ACO systems. So I think that's certainly something that we'll continue to try to work on and tease out and absolutely work with many of our partners, especially like Premier and Brookings, many of the other organizations that are working closely with ACOs to really figure out what the primary care piece of all of this is. And certainly we hold hope and fast to our belief that medical home really is what's going to make those programs successful and is driving those improvements in quality and outcomes. So Marci, did you have any final parting words or comments before we wrap up the webinar today, and certainly moving into all the exciting work that's going to be happening throughout this week and into next?
Just a congratulations and a thank you to everybody who has been working in this movement for so long. The news is terrific. We've been waiting for these evaluations to come out for some time, and we've got a lot more work to do, but clearly we can demonstrate that we are making headway.
Well, thanks so much, Marci. And again, the publication will be available widely on our website to everyone on Friday of this week, and we will be back to our regularly scheduled national briefing the last Thursday of each month at 1 p.m. Eastern Time live. So thanks again, everybody, and we look forward to seeing many of you on Friday up on the Hill. Thanks again, Marci. Bye-bye.